Wat?
Oh, she speaks Vietnamese. Good. Hi.
I think she's awesome.
She can cook for. Good afternoon and a warm welcome from Cape Town, ladies and gentlemen. It's wonderful to have you over here with us this evening. My name is Peter de Jong, and unfortunately, Professor Stephen Jeffrey is otherwise occupied at another function and engagement. So it's without further ado that I can introduce my speakers, Dr. Natalie O'Dell, and she is head of the Clinic of High-Risk Obstetrics and Fetal Maternal Medicine at the University of Witwatersrand Charlotte McLakey Academic Hospital. And she is an expert in endocrine and a qualified maternal fetal medicine. Her interests include looking after the 2 toddlers that run around her home. You'll see them there. And also a true gift in ultrasound medicine. And we're going to hear about that and see about that just now. Our sponsor today is Mindray, as you can see from the website. And it's with a great pleasure that I have Cynthia of Mindray. She's going to start with a very short video just before we have Natalie Odell presenting. Next week, we have Dr. Percy Moodley, and he's going to be speaking about aging and sexual hormone interplay. Now, we had such a wonderful, yes, that's right, Natalie, aging and sexual hormone interplay. We recently had Dr. Rudolph with us, and she gave us that magnificent talk on aging and sexual function. And it was so well received that we've been asked to do a reprise and sexual hormonal interplay with Percy Moodley. I can think of no better person for the job. He's going to be speaking about hormones and also androgens and other forms of hormonal interplay. So now a great big thank you firstly to the Pelvic Floor Foundation and also our sponsors, that's Mindray. And then, of course, next week it's Abbott sponsor. We have, in addition to our usual staff, we have Corin. Corin, can you just give us 1 minute on how do we get the CPD? Because some people have said, what's this about the new World Cup? So if you could just say, how do people go about getting their CPD points just before we start with the Mindray video?
Okay, so it works the same as it always has worked. After the webinar, you will receive a quiz. As long as you were in the webinar for at least 30 minutes, then you will receive the quiz. You submit the quiz, and then I will submit your MP number on your behalf to the HSCPA. I think I got my acronym right. And then you will receive them. They are a little bit behind at the moment with their points. So if you haven't seen your points, building up on your account yet, and you're worried about that, please don't fret. I have everyone's numbers, and they will be submitted. There's just a little bit of a delay on their side, not on our side, so on their side, and things will be caught up shortly. But if you have any questions or anything like that, you are more than welcome to email me, either info@pffsa.org or karen.bird@pffsa.org.
Thank you very much for that, Corin. That'll clear things up. Now, Cynthia, would you mind showing your video on behalf of Mindray? A great big thank you. It's so nice to have Mindray sponsoring once again after a short break. So, Cynthia, Mindray, please let her roll. Corin, let her roll, please.
Yeah.
Cynthia, say
good evening, everyone. Firstly, I would like to thank Dr. Odell for presenting. We are looking forward to hearing what Dr. Odell has for us today. From Mindray's side, I would like to say we have many OB solution with the AI technology. So the video will actually show you what is it that we have with regards to the AI. And we have many academic videos on our website. Please join us on the LinkedIn page for more info. Thanks.
Cynthia, thank you very much. I can just say that it's so popular, the Mindray presentation this evening with Dr. Odell, that we have over 350 people registered. So it's a wonderful turnout for you and Dr. Odell. And it just goes to show how important your topic is and how popular a speaker you are, Natalie. So thank you very much. Corin?
Could we just do a test? I'm getting some feedback from one of the participants or from one of the audience members who says that the audio seems to be going in and out. So if there is anyone in the audience that has my number or my email and you are experiencing auditory issues, please just pop me a mail and I'll see what I can do from our side. And again, the recording will be available in the newsletter, and you can email me if you need it. So I'm going to share my screen now and share that video for you.
Thank you. Thank you, Cynthia. That was a wonderful video. Thank you so much. And now, without any further delay, Dr. Odell and Dr. Natalie Odell, the 20-week scan sponsored by Mindray. Could you share your screen, please, Natalie?
Right. Is that visible to everybody?
Absolutely clear.
Okay, great. So thank you so much, Dr. de Jong, for the and thank you so much to the Pelvic Floor Foundation for inviting me to be a part of this webinar, and to Mindray and to Cynthia. We all work together quite a bit on this side, and it's always a great collaboration. So I think I am addressing quite an important topic, and I think it's just such an interesting discussion, because it's always interesting to know how many obstetricians are actually really comfortable with the mid-trimester ultrasound. And I think, frankly, there's actually not a lot of people. So certainly in terms of the medical legal side of things at the moment, you know, the litigation has become such a big factor. And most obstetricians are really desperately trying to refer all their patients out for their scans, so that they don't take that medical legal responsibility for the mid-trimester and the NT scan. But interestingly, in terms of the college training, it is actually a skill that we are supposed to finish our FCOGs having, and that you are covered to provide the service. But certainly I know within our VIT system, and I'm sure it's the same for other universities, it is a skill that isn't always completely optimized by the time reg time is finished. So I'm going to just focus on the simple mid-trimester ultrasound. We're not going to go into too much detail from a fetal medicine point of view and abnormalities, but really what we can expect to see, what we are expected to include and exclude in the scan, and then when to refer out. So, and of course now my screen is not sharing, not moving for us. Let me see if I can just get us to move on the
Corin?
screen.
So
Oh, there we go. How's it on your side? Is it moving?
That's perfect. Thank you.
Okay, great. So a mid-trimester ultrasound should actually be offered to every single woman, not just women with risk factors, not just advanced maternal age, but certainly every single woman in the ideal setting should get a mid-trimester scan, and ideally it should be performed from the 18 to 22 week mark. It's important because at that gestation, most of the organs have already formed. There's a compromise between dating the pregnancy and timeliest detection of major congenital abnormalities. So it should be performed by individuals who routinely perform obstetric scans and have specialized training for the practice of diagnostic ultrasound in pregnant women, which is actually every single obstetrician. Opportunity is then given at that stage to prognosticate for conditions that will influence outcomes, specifically preeclampsia with uterine artery Dopplers, and our preterm labor risk with cervical length screening. So what else can we get from our mid-trimester scan? We know it's an opportunity to compare obstetric dating with the fetal biometric measurements. So we would have ideally dated a pregnancy much earlier than this, and then we can obviously compare and see if our baby is growing appropriately. We want to identify important structural abnormalities that may alter our prognosis and our management through the pregnancy and in the neonatal period. Firstly, identifying lethal abnormalities, and then offer that patient the option of termination of pregnancy or continuing the pregnancy conservatively, and identifying abnormalities that may require fetal intervention or early neonatal intervention that we can then let the peds know that they need to be ready for. We can also identify maternal abnormalities that may alter pregnancy outcomes, so such as fibroids, women with really large fibroids that may be a risk for preterm labor or PPH. And then obviously a survey of soft markers to risk stratify the patient for chromosomal abnormalities and to make an informed decision about invasive testing. So in terms of our equipment and documentation, we want to use real-time grayscale ultrasound. We want to use 3 to 5 megahertz transabdominal transducer, have an adjustable acoustic power output controls with output display standards, which most machines will have. You want to be able to freeze your image so that you can freeze and you can go back in your frames and assess those frames slowly. You want to have electronic calipers that can measure your distances. You want to be able to print or store your images, and obviously have machines that are well maintained and regularly serviced, something in the state sector which we often struggle with. And ideally, you should be storing video clips of the fetal heart. So what are the basics? Before you start any ultrasound, it's important to counsel the patient about the benefits and the limitations of the ultrasound. Remember that you're offering her an investigation. This is an investigation. So she needs to understand why we're doing it, what the benefits are for her, and what we may not pick up, and what are the limitations. And that's important with medical legal understanding, or the medical legal side of the ultrasound. The basic prenatal screening ultrasound should always include the evaluation of whether there's fetal cardiac activity to confirm viability. You'd like to know the fetal number. Obviously, if there's more than a singleton, you would want to determine chronicity. That will risk stratify and determine your follow-up pattern. You want to look at the fetal gestational age. You want to look at the basic fetal anatomy, and then look at your placenta. Where is it located, and does it look normal? So don't forget, always use focus, magnification, and gain. That's so important in terms of getting your correct images. Don't let that little femur that you're measuring be all the way in the top corner, tiny. Bring it to the middle of your screen, magnify it, use your gain, which is making your image lighter and darker to define your image and define what you are measuring. So the detailed mid-trimester scan, you should have a systematic approach to the fetal anatomy. You need to determine for you what's going to work best. So I generally go from head to toe. You want to look at the head, you want to look at the face and the neck, make sure you look at the spine, look at your upper limbs, thorax and heart, and down to your abdomen, down to the genitalia, and down to the lower limbs. So this is a nice table that basically says what is the earliest gestation at which an ultrasound diagnosis can be made for an abnormality. And interestingly, there's a lot that you can see at your nuchal translucency scan or your 11 to 14 week scan. So those major structural abnormalities should be picked up earlier. But there are quite a few abnormalities that would be seen ideally at your 18 to 22 week scan. And obviously those earlier abnormalities, if you haven't had an ultrasound or it's been missed, you would also want to see at this stage. So what is the value of the mid-trimester scan? So this was a really nice study that was published looking at, you know, your detection rate of abnormalities for each system. And you can see really there's a massive benefit for doing your mid-trimester scan because you're picking up a majority of your abnormalities. A big pickup in terms of central nervous system, big pickup in terms of your urinary tract abnormalities, particularly your major. Cardiovascular, not always the greatest detection rate, but that is also, I think, sometimes from a skill point of view, and that there are a lot of abnormalities that aren't necessarily picked up during the 20-week scan. Sorry, I'm just going to take a sip of water. So I wanted to highlight a really, really useful document. And while ISWAG is pretty much useful for everything, one of the go-tos for all the fetal medicine people and a nice resource for all obstetricians.
Colin, Natalie, can I just ask a question? What does ISWAG stand for? International Society of Ultrasound?
Society of Ultrasound and Obs and Gynecology.
Okay.
And so they've got really, online, easy, free access, wonderful guidelines, how to do your NT scan, how to do your fetal anomaly scan, fetal echo, fetal neurosonography. Obviously, a lot of that may be better for fetal medicine, but certainly I send this stuff to my registrars all the time because there's a great need for just the basic ultrasound guidelines as well. So they are really, really helpful.
And actually, while you're getting another sip of vodka,
I know I'm having a proper throat tickle now that I'm speaking. Hey.
Yeah, but have your vodka. The website also has very nice little video clips and so
lots of webinars that are freely accessible.
So it's a
really helpful
resource, and it shows you in real life how to do these things, and also it's absolutely free. So it's a wonderful resource to embrace.
Absolutely. So starting with the head, looking at your skull and your brain, or the skull and the brain of the fetus, you would want to examine your biometry. You would do a BPD and a head circumference. You would want to make sure that the cranium is obviously intact. You would like to see your cavum, septum pellucidum, your midline falx, your thalami, the lateral ventricles, and assess the choroid plexus. Look at your posterior fossa and then assess your cerebellum and your cisterna magna and your nuchal fold. The recommendation from the guideline is that you are going to look at the BPD, the head circumference, the abdominal circumference, and the femur length, and you would measure those routinely for the assessment of fetal size. And interestingly, so ideally you would want to date all your pregnancies at the 11 to 14 week scan with your crown rump length. That's the best and most accurate way to date your pregnancy. But if your pregnancy hasn't been dated, or you don't have an accurate way of dating her, you can use your head circumference or the head circumference plus femur length at this stage to date the pregnancy. So the guidelines that are given for measuring the biometry, and this is always, how to get that perfect BPD. So you make sure that you're not missing IGR, and when you're doing your follow-up growth scans for your relevant patients, this is also important. So the BPD is taken at a cross-sectional view of the fetal head at the level of the thalami. So you can see here's the thalami on either side. It almost just looks like two black spaces on either side of the falx. And then this little square box, which is your cavum, septum pellucidum, it's at that level. And you would like to assess that there's symmetrical appearance of both the hemispheres. You see the continuous midline falx, which is only broken anteriorly by that square area, which is the cavum septum. And you shouldn't see your cerebellum in this view. And using a 90-degree, your caliper will be at 90 degrees to the midline. You would be measuring from outer edge to outer edge on your image, 90 degrees to that falx. The head circumference is in the same plane as the BPD. Most will use an ellipse function, which is measuring the whole outside. Otherwise, you can use the OFD, which is the occipital frontal diameter, and the BPD, and all of our machines will then assess give us a head circumference from that.
So, sorry, Natalie, just to go back, please.
Yes.
There
this one or before?
Yeah,
yes.
That's it. Or you can go the previous one. The BPD, did you say from outer to outer? Oh, I see. That's important.
So it is important, but actually you do, one of the little nuances with this is you need to also know how your machine is set up. So some of the machines are set up to measure BPD from outer to inner. So the guidelines say you should be measuring outer to outer, but some of the machine setup is a little bit different. So it is important to know your machine. Most people won't be able to know that, especially if you're in a state practice where you're using whichever machine you get to first. So then use your outer to outer.
Thank you.
Then we're going to look at the skull. So we've said we want to look at the integrity of the skull. You want to make sure there's no bony defects. You want to look at the shape of the skull. The skull is obviously normal, an ovally shaped thing. Now you want to look if there's a lemon-shaped skull, is there a strawberry-shaped skull, cloverleaf shaped skull, and that is associated with different aneuploidies. So lemon-shaped skull, we worry about spina bifida, strawberry-shaped trisomy 18, and cloverleaf can be some of the lethal skeletal abnormalities. Looking at the integrity of that bone, you want to make sure that obviously it's intact, there's no anencephaly, and then also looking at the density. So you want to make sure that there's continuous echogenic structure, which is well mineralized. There are some skeletal dysplasias that are associated with poor mineralization of the skull, such as osteogenesis imperfecta and hypophosphatasia. So if you're worried about the skull's mineralization, if you actually put pressure with your probe on that fetal skull and the skull gives, then that is one of the things that make us worried that the mineralization is less than expected. Then let me just move to the next one. I wanted to show you guys in terms of the planes of examination of the brain. So we've said we're going to do our BPD in the transthalamic view, which is B, but it's also important to have a look at the transventricular plane, which is A on this image, because that's where we're going to assess our ventricles and do the measurements. And then also you want to look at the posterior fossa of the brain, which is image C, and that's our transcerebellar view.
Natalie,
You want to go back? Yes.
Sorry, Karen. I can't see B because there's that panel on top of it. Can Karen,
I don't know how you just take it off,
smaller,
but you can move it around.
Can you? Oh, I didn't know.
Are you talking about the video?
So just it's the panel our images. Yeah.
You can just exit that. It's fine. Or
how do I exit?
Minimize it. There should be little dots at the top.
I didn't even know we could minimize. Thank you, Karen.
No problem.
And also, there we go. I don't know how we did it, but I think Leonie did it. And then also make our pictures smaller so I can see your pictures better, Natalie. Hang on, she's going to do it for me as well. Oh, there you go. Leonie is a star. Thank you. Yeah.
Thanks, Leonie.
Thanks, Leonie. There we go. So, that's what I wanted to see. Thank you.
So, you can see the slight differences between A and B. We've said with the transthalamic view, we're looking for these little darkened spaces on either side of the falx, which tell us it's our thalami. And if you then have a look just slightly higher on the baby's head, you would again see the cavum septum. But over here, we want to have a look at the ventricles. So we're going to look at our assessment of the ventricles now. We would measure this in the transventricular plane at the level demonstrating the frontal horns and the cavum septum pellucidum. And measurement is performed at the level of the glomus of the choroid plexus, which is basically this little tail of the choroid plexus. And you would measure basically from your calipers are from the inside wall to the inside wall. So you can see in image B where you want to place your calipers just on the inside, and normal is less than 10 millimeters. So generally when the ventricles are large, just by looking at the baby's brain, you should already get a subjective view that doesn't look normal, and then you would do your measurement and see if it's more than more than 10. Then looking at the transcerebellar plane, what you want to measure at that plane is three main things. So you can see in the little image with the colors, you're looking at the cerebellum. That's that butterfly-shaped cerebellum posteriorly, and in the center there should be a vermis, so there should be no gap. And you would measure a transcerebellum, a transcerebellar diameter, which is from one side to one side. Interestingly, this is a very nice way to date a pregnancy when you are worried about growth restriction. So the cerebellum doesn't lag behind when the baby is growth restricted. So say you've got a pregnancy and she's not sure of the last menstrual period, she's never had another ultrasound, and now you think there's growth restriction, but you're not sure. Use your transcerebellar diameter to date your pregnancy, and if that correlates with your measurements, then you know your baby's not growth restricted. But if it is significantly more, you know your baby's growth restricted. Difficulty kind of from about 28 weeks onwards is that your cranium ossifies, so it's not as obvious, or it's not as easy to see, but it is a little trick that is helpful. Then you want to measure your cisterna magna. So on that image, it's the little brown posterior portion just between here. And normal, sorry, this actually needs to change from 4 to 10. Please ignore my 2. We need to change that to 4. So a normal cisterna magna is between 4 and 10 millimeters. And then the next thing we're going to look at is the nuchal fold. So remember, nuchal fold is a measurement of the skin at the posterior aspect. So we know that at the 11 to 14 week scan, you're measuring a nuchal translucency. Once we go to 20 weeks, we're calling it a nuchal fold. And you would measure that from the outer skin line here. It's giving me a block, ignore that. So from the outer skin line, basically to the bone of the cranium over here. And abnormal is when it measures more than 6 millimeters, and it is highly specific for aneuploidy. So it's got a likelihood ratio of 10. And at the end of this talk, I'm going to address briefly what are likelihood ratios and what are their significance. And then you need to just basically make sure that it's less than 6 millimeters. If it's higher than 6 millimeters, we're worried very much about aneuploidy. And then the second thing that it can be associated with is cardiac defects in the fetus. So you would have a look even more closely at the heart of the fetus. Then I always move down the baby, have a look at the face. So the recommendation from the ISUA guideline in terms of the general obstetrician is the basic exam should include visualization of the upper lip, assessment of the presence and the position of the orbits and eyes, and if possible, assessment of the fetal profile, which I thought was interesting. So it's if possible, it's like if you can, but I do think a midline assessment of your fetus is actually very important. Obviously, nasal bone, such a big factor to have a look at this point in terms of your risk for aneuploidy, but also just your structure of your baby in the mid-sagittal. You know, the forehead tells us a lot. The chin tells us a lot. Micrognathia is really associated with a lot of syndromes. Big foreheads, bust foreheads is also associated with problems. So that mid-sagittal view is important to have a little look at. And then, like we said, we're going to have a look at our baby's face. You're not measuring necessarily the distance between your eyes or anything, the eyes at a general obstetrician's level, but you are seeing that both eyes are there and they look like in normal position. And then you're looking at the upper lip here, where you want to make sure there's no cleft lip or palate. And then the planes of examination on the face, this is a coronal view where we've said you're going to have a nice look at the soft tissue of the fetal lips and the nostrils. You can assess, and you should assess, that the fetal lenses are visible, and then you can go to the mid-sagittal view, which we've already kind of discussed, and then the transverse view that we're looking at here, where you can have a look at the alveolar ridge and the palate and all of that. But generally, this basic examination, this is where we're at for a general obstetrician. Then I always move down to the spine. So that's just my system. So examination of the spine is obviously a dynamic process. Your fetus is moving around. You should examine your fetus in 3 planes. So this is an axial plane. And you should go from the head, where you're going to cervical spine. You should follow that baby all the way down to the sacrum. And what you're basically looking for is that obviously the skin over here is intact and there isn't any splaying of your vertebrae at this point. Then you're going to look at it in the sagittal view. So that beautiful mid-sagittal where we had babies side profile, you're now going down to the spine in that view, and you're assessing that the skin is intact, there's no overlying skin defects, and that all the vertebrae are in line. And then this is your coronal plane, where you're looking at the baby straight on, and again you are assessing that the spine, all the vertebrae are in line with each other, and there's no steps or anything in that plane. And I've said we've examined the integrity of the skin. Then I move down to thorax and heart and lungs, and I don't want to get into too much detail because I think you can have a whole hour's discussion on the heart itself. It's a very detailed assessment if you're going to do a detailed assessment. But starting with the heart and lungs, you obviously want to look at your heart. You want to check that there's a normal appearance in terms of the shape and the size of the chest and the lungs and the heart in relation to that. So the heart should occupy about 1/3 of the chest. That is, again, a subjective assessment. If you are worried, you would then go into measuring the cardiothoracic ratio and the chest ratio and trying to work out if it's more than 50%. You would want to look at the heart in terms of rate and rhythm, normal rhythm rate being between 120 and 160. Then you would want to assess the four-chamber view, where you can see obviously all 4 chambers, the right atrium, left atrium, right ventricle, left ventricle, and then looking for the outflow tract. So that is a recommendation at the level of a general obstetrician, is to be able to assess the outflow tracts. Anything more than that, you are off the hook. So the easiest way to assess or get to a nice 4-chamber view, like we've got at the bottom here, is to get your abdominal circumference, which we're going to talk about now, and basically then just move your probe up that baby from abdominal circumference into the 4-chamber view. And these are just nice images of the views that we want to have a look at. So we've looked at our 4-chamber view. It's important to look at the situs of this heart. So it's difficult to use. Situs means you want to make sure that obviously the heart is pointing to the left, okay? It's difficult to use your stomach bubble to assess your situs, because if the baby has a situs inversus, the stomach is often on the wrong side also. So you're going to assess that baby as, you're going to miss the fact that the heart's on the wrong side. So what we always like to actually use here is the aorta. The aorta actually sits just to the left. I know this is like, I mean, it's just like if that's the midline, it is a little bit to the left. So the aorta sits to the left, and that is unchanged in your situs inversus. So that's why we use the aorta to assess our situs for our heart. Then we know that the right ventricle is what's sitting directly below the sternum. Closest to your aorta is your left atrium, and then you can basically work out what the rest of those ventricles are. I mean, or atria and ventricles are. And then what we are looking for when we have a look at this is obviously the rhythm of the heart is normal. We always look at the mitral and tricuspid valves, that they're moving beautifully, but we'll move to the outflow tract. So this is, if you've now assessed, if you know which ventricle is which, you'll be able to identify which is your left outflow tract and which is your right outflow tract. So if you have your left, if you've got your 4-chamber view, what you then do is you keep your probe on that 4-chamber view, and you just tilt ever so slightly towards the baby's head. So most of our babies are sitting cephalic. You tilt towards where your baby's head is sitting, and that will often then give you your outflow tracts, left first, and then as you tilt just that little bit more, you get the right outflow tract. And ideally, you would want to see that you see the position of those. They would, if you were to see them in the same view, they would be crossing each other, and that's important. The other way that you can assess your outflow tracts is looking at, so further, just a little bit superior to the 4-chamber view, you can have a look for your 3-vessel view. And that's basically looking at your pulmonary artery, your aorta, and your SVC. All 3 of those vessels should basically be in line with each other, like you see in this image, and they should be around about the same size. If you can see that, you can basically see that your outflow tracts are also normal. So there is always a debate about whether you only need to see that or you need to see both. Ideally, you should see both, but this is a reassuring finding in terms of normal outflow tracts. Then looking at your thorax, you want to have a look at the heart. We've already said you're looking at does that heart look normal in size in relation to your lungs? Remember, small lungs are always, is it because the lungs aren't developing, or is it because the heart is actually looking bigger than it should? So you look at your lungs, just see if you see any masses in your lungs, in the fetus's lungs. You want to make sure you don't see the stomach bubble up there next to your heart in your lung space. And then you want to look at the diaphragm as well and make sure that that's intact. And then we move down to the abdomen. And the biometry is pretty straightforward. We're looking at a transverse section of the fetal abdomen. You should see the umbilical vein over here, and this is an image which is, if you just tilt it 90 degrees to your left, you'll be able to match it. So this is your umbilical vein, this is your stomach, you should see a single rib, and that's the perfect place to get your abdominal circumference, and you're measuring the whole of the outside. So even if you've got a real fat little one, you want to include all of that fat, because that's your abdominal circumference. You shouldn't see your fetal kidneys at the back. Basically, for most people, you can never see the kidneys until you're trying to do an abdominal circumference. And suddenly those kidneys are sitting there in clear view, but basically you shouldn't be seeing your kidneys posteriorly. And then we usually use an ellipse to do your whole abdominal circumference. But again, you can use your diameters. So you can use an anterior to posterior diameter and a trans-abdominal diameter. And then your machine will automatically calculate your AC for you. So it's up to you what you choose to use there. So the recommendations from ISUAG is, in terms of your abdominal view, you want to see the presence, situs, and shape of the stomach bubble. So it must be there. You must see a stomach bubble. From left to right, you want to see the stomach, the umbilical vein, and you should see the gallbladder on the opposite side of the stomach, but the actual assessment is optional. You should assess the fetal umbilical cord insertion site, which you can see in that image. And you want to make sure there's no abnormal fluid collections in and around the bowel, and increased echogenicity of the bowel equal to that of bone should prompt referral. So that's echogenic bowel. We're going to have a little talk about that right at the end. Then kidneys and bladder. The recommendation is you should visualize the fetal bladder, and if either bladder or renal pelvis appear enlarged, a detailed assessment should follow. So the image on the left is the kidneys, and these are the calyces of the kidney. So another soft marker for aneuploidy, if it's more than 4 millimeters, we can be potentially worried about aneuploidy in the fetus, but we'll talk about that just now. And then just in terms of your bladder, one of the handy things of assessing whether you've got a 3-vessel cord is putting on your color Doppler at the level of your bladder, because if you've got your 2 umbilical arteries on either side of your bladder, you can assume that it's a 3-vessel cord. And then just your limb examination. The one thing I wanted to just add in here is obviously, there we said presence of all 4 limbs should be documented. So when you are going...
So presence of all 4 limbs should be documented. Is it always easy to see them? Or there's something...
Look, if it's not easy to see them, you need to spend the time to see them. So at your 20-week scan, so I'm just saying you need to know that there is an upper limb, like there's a humerus, there's a radius ulnar, and there's a hand. You need to say that you have seen your complete upper limb on both sides, and you have seen your complete lower limb. Assessment of fingers, etc., toes is not required as part of a routine, but you must document that you see all your limbs. So it means going from one side of the baby, assessing that limb, and then going to the other side, assessing that limb, and the same for the lower limbs. We've had cases of like amniotic band syndrome where we know that there was an upper limb there, that other limb was there at 12 weeks. And then you get to your 20-week scan and suddenly you've got, a partial amputation of a limb and that type of thing. So it is just very important to document.
Right.
So the femur is measured with your bone perpendicular to the ultrasound beam and with the epiphyseal cartilage visible. So the images, both images, but particularly the one on the right, is something I just mentioned earlier. Remember, anything you are measuring, magnify it, bring it to the center of your screen, use your gain to make it nicely, clearly visible so you can see either side of it, and you're measuring from the midpoint to the midpoint of the bone. So we said we're going to make sure we see all 4 extremities, the presence of all long bones, and their symmetry, length, shape, alignment, position, and movement should be assessed. So all that means is that you've looked, through that upper limb, you've been like, cool, there's a humerus, there's a radius, there's an ulnar, there's no fractures, there's no like bowing the bone, all of that. Like, you should just do a quick assessment of all the limbs. And like I said, counting fingers and toes is not required. And measurement of one femur is usually sufficient. If you've got a short femur, that's when you now need to go and assess all your long bones, measure tib, fib, radius, ulnar, humerus. But just doing your femur, and we always do a humerus as part of your aneuploidy assessment at your 20-week scan.
Natalie, just go one back, please. Just run through again. Yeah, that's it. That femur.
Yes.
Tell us exactly where to put your calipers or your cursors.
Perfect. Yeah. So we're looking at the bone, we're getting a nice magnified, and it's lying flat across our image. So it's not lying, we're not looking at an oblique view. We want a nice straight view like this. And literally the middle of the bone on that side, so the midpoint of the bone to the midpoint of the bone on that side is where you're measuring.
Okay. Because sometimes you can make it longer and shorter, just depends where you put that caliper.
Yeah, so look, sometimes if you're not getting your bone in this nice, if you've got epiphyses that are a little bit more obvious and that type of thing, but if you're using your midpoint to your midpoint, then that's usually sufficient to get an accurate measurement.
Okay, thank you.
So then just the last thing I wanted to have a quick talk about is soft markers. So remember, when we're doing a fetal anomaly scan, or when we're doing our 20-week scan, we're obviously looking for major structural abnormalities in the fetus, but we're also doing risk assessment in terms of aneuploidy for that pregnancy. Ideally, she's had a 12-week scan, she's had biochemistry, etc., which is not in every setting, but that would be the ideal. But at that 20-week scan, it's still an opportunity for us to risk assess that pregnancy for aneuploidy. So what are soft markers? So remember, hard markers are structural abnormalities. There's massive cardiac abnormality, there's an omphalocele. Those are hard markers. I want to talk a little bit about soft markers. So a soft marker is a fetal sonographic finding that is not an actual abnormality of development and is generally has no negative impact on the baby's health, but it does, however, increase the likelihood or the odds of there being an underlying diagnosis such as Down syndrome in that pregnancy. So identification of these soft markers for fetal aneuploidy requires correlation with other risk factors, including history, maternal age, and maternal serum testing if it's done. So it's often difficult to assess this in isolation. You need to say, well, I've seen X, but what else is there in this individual case which makes me worried or makes me less worried? So this is just a table which is a simple clinical summary for management of specific soft markers. So if we see, so these are some of the soft markers you may see. So ventricular megaly. Remember, we said a normal ventricular measurement is less than 10 millimeters. This is quite a handy thing for us to have, particularly if we are just managing these cases without fetal medicine, in terms of what we're going to do going forward. So looking at a ventricular megaly, looking at choroid plexus cyst, looking at a hypoplastic or absent nasal bone, looking at a thickened nuchal fold, intracardiac echogenic focus, etc. We're going to talk about each of these or some of these now. So these likelihood ratios, this is our WITS protocol, and we use it. So I'm quoting our WITS protocol in terms of what a likelihood ratio is. So if you whenever I ask this question, I mean, amongst our registrars and everything, and not a lot of people understand likelihood ratios. So a likelihood ratio, we said, is something that increases our risk of there being an abnormality. So what you need to always do is you take your background risk for this patient, and there's lots of charts, etc. So it says you are a 40-year-old woman and you have a background risk of having a baby with Down syndrome, which is 1 in, I'm going to make the numbers easy. Likelihood ratio, I mean, the background risk is 1 in 50. So that's her background risk. If you were to now scan her and you find no soft markers, your likelihood ratio is 0.3, which means you divide 50 by 0.3, which means her risk is significantly decreased. But if you find some of these soft markers, her risk would be increased. So say you find a raised nuchal fold that's more than 6, a likelihood ratio of 10, which means she's now got a 10 times increased risk of having a baby with Down syndrome. So her risk goes from 1 in 50 to 1 in 5. And if you were to take her, even say there was a hypoplastic nasal bone, her risk would be 1 in 1 of having a baby with Down syndrome. So you can see that whatever your background risk, you would then divide that background risk by your soft marker likelihood ratio to now work out her odds of having an abnormality. So this is a handy table just to have. So yes.
Just go back here. What is a pyelectasis, if I may ask?
No, perfect. So good question. So when we had a look at our kidneys here, I said we look at the calyces and we measure these calyces. So you measure it in an anterior posterior diameter, and more than 4 millimeters is considered dilated, and we call that pyelectasis.
Oh, pyelectasis.
Yes. So more than meters, the renal pelvis being more than 4 millimeters is what is a likelihood ratio only of 1, which means, and it's interesting, I wanted to just point out 2 of these things. Pectosis and echogenic focus in isolation only has a likelihood ratio of 1, which means her is if that's the only thing you find on your ultrasound. But let's have a look at a few of these things. So echogenic bowel, this is defined as fetal bowel with homogeneous areas of echogenicity that are equal or greater to that of surrounding bone. That basically means, can you see how bright down and make your image very, very dark? Your bowel would still be shining bright like your bone would. So that's when you say they have equal echogenicity. It can either be focal or multifocal throughout the abdomen. And this has a likelihood ratio of 3, which means if you pick that up, you are 3 times more likely to have a baby with Down syndrome than your background risk. There are other causes for echogenic bowel, which you would need to investigate for. So cystic fibrosis in the fetus. So, if it's maybe the mother's got cystic fibrosis, or it's white English heritage, they would be more likely. You may want to test for cystic fibrosis. The other thing that causes echogenic bowel is if the mom's had a lot of bleeding. So she's come in with recurrent threatened miscarriages, etc. The baby swallows the blood, and then the red blood cells sit in the bowel, and you get more echogenic bowel. Also, congenital malformation of the bowel. And then intrauterine infections. So if you pick up a baby and you've got echogenic bowel, you would also want to do a torch screen for mom as one of your differentials for the causes of echogenic bowel. So like I've said, you would do further assessment, and you would do possible karyotyping, testing for congenital infection, and then DNA testing for cystic fibrosis if it's warranted in that setting. Then we said mild pyelectosis is defined as hypoechoic spherical or elliptical shapes within the renal pelvis. So 4 to 5 or more, and less than 10. Once you get those renal pelvises being more than 10, that's when we get more concern for actual structural abnormalities of the urogenital tract. So maybe the bladder is also distended and there's posterior urethral valves or something like that. There's an obstructive uropathy. But when it's mild between 4 or 5 and 10, then you can say mild pyelectosis. Like I've said, we've said it's a likelihood ratio of 1. So if it's in isolation, you can consider aneuploidy testing. You can counsel the mom, but it doesn't change her background risk. And then just your follow-up would be a neonatal renal ultrasound. So once baby's born, the baby would get a renal ultrasound and just basically see if that clears. And it usually does, if it's not associated with aneuploidy. And then the one thing, single umbilical artery, which has fallen out of favor as a soft marker, because it's actually associated with a few things, and aneuploidy isn't actually anymore one of the most common causes of a single umbilical artery. So this is an absence of one of the arteries in the umbilical cord, and the picture on the right is what I showed you when we were looking at the bladder. Do you see how nice and obvious it is there that we're missing one of the arteries? But it can also be assessed when we do a transverse view of the cord, and we're looking for that Mickey Mouse sign. So basically the head of Mickey Mouse and the big 2 ears, to know that there are 3 vessels. And this is not found to always significantly be associated with aneuploidy, but it has been associated with underlying renal and cardiac abnormalities, as well as low birth weight babies. Interestingly, moms that are taking lithium, and also more common in diabetics. And then echogenic intracardiac focus. So this is one of the most common causes for referrals to fetal medicine. So it's defined as a focus of echogenicity comparable again to bone. So you see that bright spot in the ventricle of this baby, and if you turn your gain all the way down, you're still seeing that bright spot. It's got a likelihood ratio of 1. So if it is seen and there are no other risk factors, her background risk is not changed. If you're seeing it and she's 42 years old, or she's had a previous child with Down syndrome, then your you're a little bit more concerned. But in an isolated finding in a young patient, you can be reassured that her background risk is unchanged. Where it does become more relevant is when it's right-sided and when you start seeing more than one echogenic focus, then you are more concerned that there's an aneuploidy and you would offer testing. So again, we said, if found, evaluate for other risk factors for aneuploidy. So other soft markers is what's her age, what are her screening results if she's had biochemistry. And then a thickened nuchal fold. So we looked at how we would do our transcerebellar measurements, and that's where we would measure our nuchal fold. Very high likelihood ratio, a likelihood ratio of 10, which means if you see it, significantly increases your risk for aneuploidy. And it's the skin thickness in the posterior aspect of the fetal neck. We know how to measure it. And then it's also associated with some of the other non-chromosomal abnormalities, so like single gene abnormalities like Noonan's, skeletal dysplasias, and then I said also cardiac abnormalities. If you see this, you must offer genetic testing. And then ventriculomegaly, we said more than 10 millimeters is defined as a mild ventriculomegaly. Mild ventriculomegaly is associated with aneuploidy. Again, same kind of thing with your kidneys. Once you get more than 15 millimeters, that's when you start worrying about true structural abnormalities. So defects in terms of how, stenosis of the aqueduct and that type of thing, actual structure abnormalities. But mild ventriculomegaly is associated with aneuploidy. It's also associated with other non-chromosomal causes, such as agenesis of the corpus callosum, vascular abnormalities, and then obstruction within the ventricular system. And you should offer karyotyping and also work up for fetal infections. And then I've only got one or two more slides. Choroid plexus cysts. So we said we're going to look at our baby's brain in the transventricular view to measure our ventricles. We want to look at the choroid plexuses and see if we see any cysts. So these are sonographically discrete small cysts found in the choroid plexus within the lateral ventricles in this transventricular plane. The size of them is not significant. You can see them in normal fetuses, but they are associated with trisomy 18. The important thing with choroid plexus cyst, though, or with trisomy 18, is it's virtually hardly ever found that you will only see a choroid plexus cyst. So if it's an isolated finding, you can be quite reassured, although you would probably maybe want to do an NIPT for that patient. But generally, trisomy 18 comes with the cardiac abnormalities and the diaphragmatic hernia. So this is just an additional finding. But in isolation, if you're seeing a choroid plexus cyst, it's got a likelihood ratio of 1, so it doesn't change your risks. And then a short femur, we know how to measure the femur now. A measurement below the 5th centile has a likelihood ratio of 1.6 for aneuploidy, so particularly associated with trisomy 21, but there can be other causes for short, long bones, so skeletal dysplasias and growth restriction. Those would be your top 3 differentials for a short femur. And a short humerus, a bit more significant, with a likelihood ratio of 4. So that is quite, we said it's not routinely part of the screening obstetric ultrasound. I always do it as part of just a femur and a humerus, as it does have quite a significant likelihood ratio for aneuploidy. And then lastly, our absent or hyperplastic nasal bone, very, 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 very significant. Likelihood ratio of 50 increases your chance of that baby having an aneuploidy by 50 times. So it really is significant. You would always measure the nasal bone length if you're worried that it's hyperplastic, and you would use a chart for nasal bone measurements in your setting. And then, this was just a meta-analysis that was released in 2013, and the likelihood ratios are a little bit different. They looked at lots and lots and lots of studies to basically adjust the likelihood ratios. I've put them in here. All the way to the right is the likelihood ratios, quite similar to the ones I've quoted in our study. I obviously like our Wits ones just because I'm familiar with them, or like it's our routine. But that is the study, the pooled data for the likelihood ratios of all of those. And that's it.
Oh, that's a wonderful talk. Natalie, can you just go back to the likelihood ratios, please? we've got some questions and answers. We'll run through them quickly. But one
Yes.
quickly one is, you know, when you do the screening, they want to know the age and the race and the smoking status, blah, blah, blah. Do they change that much? For example, your likelihood ratios in your population versus Kypros Nicolaides' likelihood ratios in London. Does it make that much of a difference?
So it does make a difference because so for example, African race changes some of your and that's really a lot more significant in your first trimester biochemistry. So the smoking does decrease some of your biomarkers that you would be testing for in your first trimester biochem, and same with race. So it is important to fill in those details. If you've got those details, all it means is that we are putting in all that information that will give us a slightly more accurate measure of our risk assessment. So it does make a difference. In terms of, it doesn't change our likelihood ratios, although this likelihood ratio study or table that I've put in there, so ESUAG, this is from ESUAG as well, and Prof. Nicolaides is obviously always on all of these things that are released. So it is a little bit different per population group, like things like a nasal bone. In the Asian population, a normal nasal bone is smaller than in an African population. So you would want to use your population specific charts if available to you.
Okay, thank you very much. Now, if we can just run very quickly through a couple of questions because we're almost out of time. A very informative presentation. Thank you very much. Can the presentation be made available for the attendees on email? And Karen will definitely be able to answer that question. The answer is yes. Tembani Matabata says, what is a positive stroke negative likelihood ratio?
Oh gosh, now you're asking me to go back into my stats. We don't use negative or positive likelihood ratios in terms of our risk assessment.
You just do
we just use these specific numbers. I mean, yeah, you wouldn't be given a differentiation between a negative and a positive likelihood ratio.
Okay. The last question, Habib, who prefers to remain anonymous, from Kenya. What is meant by the ALARO principle? I've never heard of an ALARO principle.
So the ALARO principle is basically, it's in terms of, it's your lowest possible exposure. And it's actually more in your first trimester, or it's in all ultrasound. Essentially, it's a safety principle in ultrasound. And it's particularly for the use of, it's for all ultrasound, but it's particularly for the use of Doppler, because there is a principle that ultrasound and Doppler produces heat. So if you are going to take your 12-week baby and you're going to put that Doppler on and measure that fetal heart for 40 minutes, you are actually creating thermal energy, which can injure the fetus. So the ALARO principle is basically minimal time of exposure. If you read the ESUAG guideline on the 11 to 14 week scan, you shouldn't actually be using Doppler at all for assessment of fetal heart. And when you're doing like your measurement, your pulse wave to measure your fetal heart, you should just be measuring your fetal heart, get that value because it's part of your screening, but not like playing it for 20 minutes so mom and dad can get this extended video. So it's actually something that is certainly all the international and the local bodies are trying to stress that we are minimizing our exposure to energy to the fetus.
Okay, thank you very much indeed for that comprehensive explanation. I remember a couple of years ago, we had a gynecologist doing color Dopplers on tiny babies of about 6 or 7 weeks. Not realizing that's not a good idea. It's a very bad idea, in fact. The final comment from Corin's wiped it off, from Dr. Froelich, and he said it's a wonderful presentation and you've done some beautiful slides, and he'd like to commend you. That was the gist of
Thank you,
what
that's very kind.
is a colleague of yours up there. Now,
Yes.
at that point, Natalie, I'd like to, on behalf of all of us, the 350 people logged on, to say thank you very much. It's wonderful to hear your presentation. You taught us a lot. I'm hoping Karen sees fit and you see fit to have a rematch, maybe on the 12-week scan, and do exposition, just like what you've done on either an early or later, because it was so wonderfully informative. So thank you to Mindray for sponsoring. Next week, don't forget Percy Moodley, and we're talking about sexual interplay. And Safe Home, Natalie, a wonderful presentation. Thanks once again. And Ali Murudu says, thanks, Nat. Do you know Ali?
Yes, I know Ali very well.
Oh, well, he or she says,
Yes.
thanks, Nat. And we would
Yes.
say thanks to everybody
Thanks,
that
Ali.
logged on. And you should be getting your questions any minute now. And look forward to seeing you then next week. Final thing is, remember, we've got the 5th and the 12th of October. It's holidays, so we won't be having presentations the 5th of October and the 12th of October. You can diarize that now. Thanks, safe home, and God willing, we see you safe and sound next week. Thank you, Natalie.
Wonderful. Thanks, everybody. Bye.
Bye.
Oh,